Welcome to A&E Talk. Today we're going to discuss a little more in detail about the article I previously discussed in my prior video, and this one is about the pre-hospital clinical signs which tend to be a very poor indicator in diagnosing a raised ICP following a traumatic brain injury. And in order to discuss this topic in detail with me, I have a friend and a colleague, Dr. Ranjit. Hey Ranjit.
Hello Noel, good to see you.
It's good to see you too. Tell a little bit about yourself.
Yep, so again, like I said, my name is Ranjit. I work in one of the hospitals in Bury, UK, and my role is an A&E middle grade doctor. I've been working here for the last 4 years now.
Oh, that's great. Awesome. So, before we dive into this paper, I just want to ask, do you have any pre-hospital experience? Have you been part of a pre-hospital team?
So, I haven't been working pre-hospital here after coming to the UK. I've done some pre-hospital work back in India. It had something to do with mainly transferring patients between one hospital to the other, but that was the extent of it and nothing beyond that.
Alright, so same here. I never done any pre-hospital work, neither in NHS or back home, but I do have similar transfers. I've done patients between hospitals, between EDs and between ICUs. Said that, there are quite a lot of revelations this paper brought, and I was quite intrigued. So I thought I would make a detailed discussion about it. So that's the reason I dragged you here. So I'm going to start by saying, we know when patients get a traumatic brain injury, when their principal insult happens to the brain, as a first responder, either as a pre-hospital or an AD, when you see a severe traumatic brain injury, your goal is to prevent a secondary brain injury, and by doing that you're minimizing the ischemic penumbra. So the goal has always been is early recognition and treatment of that ICP. So my question to you is, how and why do you think it's very important to find whether the patient has a raised ICP in a traumatic brain injury?
In cases where patients have traumatic brain injury or suspected traumatic brain injury, I think time is of the essence. Okay, with time and no proper treatment, secondary brain injury sets in, and like you said, the ischemic penumbra becomes irreversible, and you get the primary brain injury expands and includes, even normal brain tissue. So we need to act quickly and swiftly. So that's why it's really important to, when we get a patient who comes to, A&E, we need to get their history quickly. We need to make a quick clinical assessment. And so there are certain signs, there are certain symptoms we rely on, which are used to judge if the person could have raised intracranial pressure. When it comes to clinical symptoms, we ask for things like any headache, any vomiting, nausea, any seizures post-trauma. Then we also look for signs such as a drop in the level of consciousness, the way we put it as Glasgow Coma Score. So we see what the GCS is. Then we look for other signs such as the size of the pupil, and we look for like what we're going to discuss as well about the Cushing reflex.
Great. So I agree. Time is of essence, and trying to find that raised ICP is very, very vital. So this pre-hospital treatment has a guideline, which I'm just going to quickly run through here. So they use a hypertonic saline, which is 500 ml of 5% NaCl. And they give a bolus of 6 ml per kilogram with a maximum of 350 ml. And some team use an alternate mannitol instead of an hypertonic saline. And they also do the other protective measures to bring down the ICP, such as head elevation, sedation with paralysis, giving adequate analgesia, and they're doing a neuroprotective ventilation, which is normocapnic and normal oxygen level. So this is obviously their guideline that they follow in a pre-hospital setup. Do you think this is any different from what we do in ED?
I think this is very similar to what we do in A&E. And if you look into the ATLS guidelines on how to manage someone with traumatic brain injury, they say exactly the same as you mentioned about head end elevation 30 to 45 degrees, avoidance of any neck collars with straps around the neck, and when securing the endotracheal tube to avoid any ties around the neck as well. Then going for some kind of intravenous drug therapies to reduce intracranial pressure, such as mannitol or hypertonic saline. Some places even advocate diuretics. Then also paralysis, sedation, pain control cannot be overemphasized. So this is what we use as standard in our hospital as well.
So we both agree it's very appropriate, and it seems to be the first line treatment for any kind of a traumatic brain injury with a hint of a clinical sign of a raised ICP. So we know in ED we have certain luxuries that the pre-hospital team might not have, which we will touch upon a bit later. But I do want to emphasize that the pre-hospital clinicians rely largely on clinical signs to identify the raised ICP. So the clinical signs in question today are the GCS, the pupil, and the Cushing's triad. So my question to you is, are they good enough?
So I'll talk about them one by one, starting with let's talk about the Cushing reflex. So the Cushing reflex, it's a physiological nervous system response to acute elevations in intracranial pressure. It's also known by certain other terminologies such as vasopressor response, Cushing effect, Cushing phenomenon, Cushing's triad, Cushing's law. And so what you see in Cushing reflex is there is a raise in blood pressure along with bradycardia and irregular breathing. So that's the entire triad. And this is seen mostly in acute raise in intracranial pressure. That's really important to know. So someone or some conditions where if they have a slow growing tumor like a meningioma, like a large meningioma which has been growing for months on end, you don't really see this kind of a phenomenon in these groups. So that's important. The other important thing is Cushing reflex may indicate brain herniation or death is imminent. So that's important. And this is a late sign of increasing ICP. So this puts things in perspective. If someone, you see in A&E or in a pre-hospital setup, and if they already are displaying signs of Cushing reflex, this could mean that it's already too late. Okay, it's easy to spot. Okay, it's easy to spot like a spike in blood pressure, irregular breathing, bradycardia, but this should also make us worry more that this is a poor prognosis for our patient, and now we'll be instituting measures to reducing secondary brain injury when I think it's already too late. So this is something to think about. And also, what's interesting is Cushing reflex is seen in about a third of patients. So 2/3 of patients don't really display this kind of a reflex, and even if they do, they might just show probably the spike in blood pressure or bradycardia or irregular breathing, sometimes none of them. So that's about Cushing reflex. Moving on to GCS. So the way we deal with GCS is in ATLS, at least head injuries and severe traumatic brain injury is classified based on GCS into like mild, moderate, and severe. Severe being if it's below 8, that's severe traumatic brain injury. And what we worry along with that is we're worried that the person won't be able to protect their airway, okay, and can aspirate their own secretions or vomit. So there's a need to perform rapid sequence intubation or get the anesthetic team down and secure the patient's airway before we can move further. So this is, when it comes to GCS, this is what we use commonly in hospital. With that being said, GCS by itself can be brought down because of many other reasons apart from traumatic brain injury. So the person could have taken some opioids or any other intoxicating drugs, and they could be the reason why the person has a drop in GCS. So GCS, I think we need to take GCS along with something else. So along with another clinical sign or along with the right context, GCS makes more sense. But by itself, I don't think we should purely act on GCS. That's just my opinion. Moving on to pupil size. So we do look at pupil size very often when it comes to evaluating head injury. And as far as I know, there is no normal cutoff when it comes to pupil size. All we look for is pupil reaction. We see if they are reacting equally, bilaterally, to light. We look for any, we check the swinging light test as well. But we don't really know what's a normal cutoff. So I think that was really interesting when I read this paper you shared with me. I was really interested. It was interesting to know that there was no real cutoff when it comes to differentiating what's abnormal and normal pupil size. I think as clinicians we rely on our experience by seeing many pupils, and we kind of roughly gauge what an abnormal pupillary reaction would look like. Bottom line being, if a pupil is dilated and fixed, or if one pupil is, if the pupils are, one is reacting, one is unreacting, that's abnormal as well. And this could point out to raised intracranial pressure, plus or minus herniation of the brain or herniation pressing on intracranial nerve.
Yep, I agree with what you just said, and as you rightfully pointed out, it was a big revelation to me too, to find out that there was no universal cutoff for any of these things. So the pupils or the components in the Cushing's reflex, like what is high blood pressure, what is bradycardia, what is a cutoff. So all of that we'll get in a bit later regarding these clinical signs. But I thought this will be interesting to point out right now, is that this study that I'm quoting down have shown that using a clinical sign along with the radiological imaging to guide a treatment and to diagnose a raised ICP has been found to be equivalent to a direct ICP measurement in terms of an impact of a patient's outcome. So basically, something that's what similarly we do in ED, we just don't do any invasive methods to measure that ICP. So we do our clinical bit and then club it with our radiological finding, mainly the CT, and find out whether the patient has a raised ICP, or at least a sign of raised ICP in a CT, such as a midline shift or a mass effect or an edema or any kind of an impending herniation. So that has been proven to be equivalent to a patient who undergoes an invasive method to find a raised ICP, and they both have been an equal outcome. So that's quite something very interesting. But moving on, so obviously the pre-hospital team does not have the imaging bit, which was the luxury I was talking prior. So now we are in a pickle. Do you think we have any solutions for that?
So, while reading for this, for preparing for this talk along with you, I did some reading and I came across. So what's interesting is Cushing reflex. Okay, the one which is commonly used in this paper by the pre-hospital clinicians. They look at, like I mentioned about, they look at high blood pressure, bradycardia, irregular breathing. So these are the signs they look for. But when we look more into Cushing reflex, it occurs in certain stages. So in stage 1, you've got where the blood pressure rises along with a raise in heart rate. So initially, the heart rate rises because of sympathetic stimulation that's trying to, overcome, it's trying to increase the MAP to overcome the intracranial pressure. So stage 1 is increase in blood pressure along with an increase in heart rate. As time goes by, it steps into the next stage, stage 2, where BP remains high, but bradycardia sets in. The mechanisms behind bradycardia is still debated. The popular theories out there are raised blood pressure gets sensed by the baroreceptors of the aortic arch, and that triggers a parasympathetic nervous system activation. Versus the other theory is apparently there's no role for these receptors outside the cranium. Rather, it's a direct compression of the intracranial vagus nerve. Whatever the mechanism is, this is the reason for one of these reasons, this is the cause for bradycardia. So stage 1, like I mentioned, is raise in blood pressure along with raise in heart rate. Stage 2 is blood pressure remains high, and then comes in bradycardia. The last stage is where there's brainstem dysfunction secondary to this raise in intracranial pressure, and this is where you get your Cheyne-Stokes respiration. So my suggestion would be, if we were to rely on Cushing reflex in the pre-hospital setup, maybe we could advocate using this high blood pressure along with a raise in heart rate. And if we kind of adopt this lower threshold to diagnosing the Cushing reflex, maybe we might be able to intervene much earlier. But I think this is a good area to where research can be done in the future to find out if this actually makes a difference, because now it's purely speculation.
Of course. So just to reiterate, we were talking about the stage 1, which you are advocating. We can use the stage 1 as an early sign in which you have high blood pressure and tachycardia. And this, to simplify to the audience, is that cerebral perfusion pressure is your MAP minus your ICP. So simple math is that this number has to obviously get higher than this number for you to get a positive number. So your MAP technically has to go up to compensate for the raised ICP. Otherwise, you'll end up having a negative number, which is what we don't want, a raised ICP. So there are a couple of issues that happens with this. One, if we are trying to hunt for the stage 1 to see a high blood pressure and a tachycardia, but I would say that would be a normal sympathetic response for anyone who gets into some kind of a trauma. Wouldn't you agree? They would have a high blood pressure and they would have a tachycardia for a sympathetic stimulation. And second, a patient who's on, let's say, a beta blocker, but they can't get a sympathetic stimulation, is also would not show that early sign to us. And the studies have shown in elderly population, in spite of significant transtensorial hematoma with mass effect and midline shift, they would not show the red flag clinical signs of raised ICP. And you have the obvious culprit is not all traumatic brain injuries are usually isolated. They have multi-organ injury, and one of the most common trauma induced is the hemorrhagic shock, hypovolemic shock, because of loss of blood from the trauma. And when you tend to go on the other route, now they are intravascularly quite depleted to raise and show an adequate Cushing's response. So there's quite a lot of caveat with this very particular thing. And obviously, as you said, GCS rightfully, it is multifactorial. There could be multiple things that could affect. So you could, as you said, we can't solely rely on that. And especially when it comes to trauma, it can go this way or other way. So the trauma causing a low GCS, or something that, like you said, intoxication or a drug intake of low GCS causing the trauma. So, yep. And the pupils, that's again a whole different ball game. So there's quite a lot of uncertainty regarding these clinical features, and just solely relying on it. So diving deep into this paper, which is what this paper is trying to solve these issues. So they're trying to establish an evidence-based cutoff values. So they want to put hard numbers and see, will that increase a diagnostic accuracy? All right. So the methodology, the results, the study limitations, these are all in my previous video. So I don't want to go through the same thing again. So I'll just leave a link below the description in case if you want to see that. And this study also had quite a lot of limitation, which you would have gone through. But I do want to discuss a few findings with this paper, which I found quite interesting. So flat out right, they say the clinical signs are poor predictor of raised ICP, as if the same thing we both have been discussing, because they all tend to be late signs. When we pick it up, these pathologies tend to be late signs. So my first question is, do you agree with the conclusion of this paper?
I absolutely agree with this paper's conclusion. I think the authors, their assessment of the reality is true. It's on the point, where clinical signs are indeed poor predictors of raised ICP, and it doesn't matter. So they've demonstrated in this paper, even despite giving cutoffs, arbitrary cutoffs to each component of the Cushing reflex, GCS, the size of the pupil, despite that, it still couldn't improve, the sensitivity of these tests, so-called tests, though clinical tests. And this is shocking because there's a lot of reliance on these clinical signs, not only pre-hospital, but sometimes also in A&E, sadly in A&E, despite us having, technology close by. There is sometimes, an over-reliance on these clinical signs, and I think this culture needs to change, and we need to go to a method that really works, that's really safe for our patients. Also, while apart from reading this paper that you shared with me, I was also interested to know, so when preparing for this talk, I wanted to look at raised systolic blood pressure. I wanted to look at bradycardia, irregular breathing, because when you see Cushing reflex, they don't really give you these values. So I had to go individually to find out cutoffs for raised systolic blood pressure. So where this took me was, if you look at the JNC, the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, and the American College of Cardiology, ACC, the American Heart Association, what they advocate is your elevated systolic blood pressure starts from 120 to 129, and your the group that needs treatment for high blood pressure is more than 130 or 80. But when you see people who come to A&E, or someone with a head injury, for some reason you're looking for numbers that's like 170 or 160 for some reason. But if you go purely by definition that's advocated by an organization, you can't be going at blood pressures of 120 to 129. You can't be looking at blood pressure of 130 to 140. You're looking for a higher number. And I really don't understand where this came from. It's probably from practice that we've observed patients who come in with severe traumatic brain injury, and for some reason their blood pressures are like much higher than these groups. And so that's the American side of things. But when you look at the European Society of Cardiology, the European Society of Hypertension, they advocate a higher grade, like hypertension cutoff. So the grade 1 hypertension for us is 140 to 159, and that's what we need to be looking for. With that being said, it's just that there's so much uncertainty even between guidelines in America, guidelines in Europe. It's just adding to the confusion, if you catch my drift. And when it comes to bradycardia, that's fine. It's very arbitrary. Less than 60, that's bradycardia. When it comes to irregular breathing, I think this is a very difficult clinical sign to elicit. So you need to be, basically looking at the patient's way of respiration and see if it really correlates to the Cheyne-Stokes respiration, which I think is, it's just theory. I really don't think that's a useful clinical sign, unless you see really classical, and I really don't know how many people or how many patients present classically as the Cheyne-Stokes breathing, where you get a gradual hyperpnea, a gradual hypopnea, and then apnea. I really don't see that happening that often.
True. So you brought up a really good point. So they just plain out said hypertension, and you rightfully went through two very major organizations and their definitions of hypertension, and that's not what they meant exactly. You're not going to say, oh, that's 129, oh, that could be a Cushing's. No, as you said, we're looking for a high number, but what is that high number? Nobody really gave, and that is something is extraordinary for us who have seen quite a few traumatic brain injuries with raised ICP. We look at numbers like 180, 190, 200, and we're like, yeah, something is going on. But where was that cutoff? Where is that cutoff? We never knew. So for the audience, I'm just going to read out the cutoff which this paper has established is they have made the systolic blood pressure of more than 160 and heart rate less than 60 and pupil of more than 5 millimeter. Surprisingly, there was no universal cutoff for the Cushing's and for the pupil in a traumatic brain injury. But at the end of the day, in spite of these authors putting a cutoff, the diagnostic accuracy did not improve. So what's your thought? What do you think is happening here or not happening?
I still think that your clinical signs are indeed valuable when you see them. Okay, so when you see the clinical sign, I think that's valuable, but the absence of clinical signs should not make you lay back thinking that this person or this patient, does not have a significant brain injury going on. I think we need to kind of, change our approach a bit, a clinical approach here in this instance, from solely relying to seeing things like the Cushing triad or the pupillary size GCS drop. I think we need to adopt a lower threshold to managing these patients, and we need to come up with a better strategy that we have at our disposal, like timely CT or bedside measurement of the optic nerve sheath diameter, what I've come across is, and so I had a look into the sensitivity and specificity of clinical signs that we use in traumatic brain injury, and you can tell me if these are the figures you found out as well. So these clinical signs, their sensitivity and specificity, they vary based on what cerebral perfusion pressure the patient has at that moment in time. So when the cerebral perfusion pressure is less than 15 millimeter mercury, the sensitivity of clinical signs go up to 93%, but the specificity is like a coin toss, just 50%. When the cerebral perfusion pressure is less than 50 millimeters mercury, the sensitivity drops to a sad 13%. The specificity, on the other hand, goes up to 77%. So, the clinical signs by themselves are also late indicators of what's going on inside. So you get most of these clinical signs when it's already too late, when your cerebral perfusion pressure is already too low, and there's a lot of damage happening already. So I think we need to move away from clinical signs and find something better. That's what I think about when I read this paper and did some reading on my own. I think we need to adopt a new strategy.
I agree. I totally agree. Just listening to those numbers and that wide range of variation, again, doesn't really give much of a confidence, does it? So one other thing I want to point out regarding the hemorrhagic part of a trauma patient that this paper touched upon. So they call those patients as code red. So anybody in a code red meant is that either as a pre-hospital or in hospital, they had a blood transfusion because of the ongoing blood loss. So unfortunately, it's a very small cohort study in this paper, these code red patients, and they said for these special patients, the strategy, you can change a bit of a strategy by saying you can have a bit of a higher heart rate and a lower blood pressure threshold, and that might increase the sensitivity. But again, that's one of the limitations, is that it's a very small cohort of patients in this entire paper, is that code red. So we can't overly rely on this recommendation. But at the end of the day, again, there is just no clear-cut cutoff, and we have way too many variations of people presenting with a traumatic brain injury. There's one example that I want to say that recently happened is when I'm currently in my IT rotation. And I had a recess call at 2 a.m. Saying that there was a 70-year-old lady who fell down, was brought in with confusion, and a CT was done in A&E, and they found out she has this huge hematoma. It's just a huge subdural hematoma, increasing in size with a midline shift and a mass effect. And obviously her GCS is just dropping. It's just she presented with confusion with 14, and now it's around somewhere 13. So when I went there, I saw her, examined her, and then I saw the monitor naturally, and you'll be surprised. Her heart rate was 72, and her blood pressure systolic of 210, quite high. And she was breathing okay. She had a good respiratory rate. There was no apneas or any shallow breaths or signs of hypoventilation or hyperventilation, none of that. She was breathing normally without any workup breathing. But then the only off thing over there is the blood pressure. With a background history of a normal heart rate, it was around 72 and 74, if I remember that correctly. And surprisingly, she's not someone who was on a beta blocker. She has no past medical history of a hypertension. Obviously, I'm going there with a retrospective eye, with knowing the CT results. But surely a presentation raised all the right red signs: confusion, falling or fall, constant degradation of the GCS, and well, the vital is not normal. So you have a vague things happening, but obviously we pick these things up and we come to a conclusion. Okay, she had a fall, GCS is low, she's a bit confused, and it's progressively getting worse. So we know something is happening. So my point here is that something is happening, is what it is. It's more like a gut instinct, or more like okay, this could be this, 1 + 1 could be 2. So we don't have a very hard and fast rule to say, well, if it's DKA, you to have your pH, your bicarbonate, your blood glucose. It's not like a line drawn. And to conclude that story, I had to, get an outline to get a proper blood pressure, and then I had to intubate her, and we had to transfer across to John Radcliffe, to the tertiary center under neurosurgeons. So clinical signs, yeah, they are helpful in raising our hairs, but sensitivity and specificity, it's all over the place. So we are almost at the end of our talk, so I want to ask one last question to you. So, over-treatment in a TBI patient, all right? Do you think that's an issue? You think this patient might have a raised ICP? We're still talking pre-hospital setting, which obviously you can apply to A&E. So you are suspecting a raised ICP in this traumatic brain injury. Just treat them. Treat them with hypertonic saline, or treat them with mannitol. But the point is over-treating everyone is an issue.
I think it would be an issue. So when we, over-treat people, especially with drugs like hypertonic saline, it's not a benign drug, so it's basically concentrated sodium chloride, and it can definitely cause an electrolyte imbalance. People can be left with really high sodium, high chloride, and this, I think in order to safely say that there's no harm, I think we need like a big multi-center study to really look into this subject, whether over-treating is an issue. And even mannitol, it's not a safe drug. It basically causes diuresis. It's an osmotic diuretic agent. So you're causing patient to get dehydrated. And if you're not really sure if this person has, raised intracranial pressure, I really don't think this is safe. I think there's a chance for harm in these people. If we overtreat, there's a chance for harm. So it's not a completely safe intervention. If you ask me, things like, sitting the patient up 30 to 45 degrees sounds fine. We are happy for that. And avoiding things like that's restricting around the neck. Again, I think that's fine. That's safe. Obviously, people who have head injury, they also come with cervical injury. So we need to be wary of this fact. And we can adopt other means of, keeping their neck straight, like keeping blocks and tapes around. And if the patient is awake and sensible, you just ask them to, stay still, basically. So I think certain interventions for secondary brain injury prevention are okay. But some of them where you need to give them, like hypertonic saline, mannitol, I think can do harm. And this needs to be looked into in more detail and for future research.
Wonderful. I agree with you. So the theoretical part of the issue would be like, you're loading them with high salt, so you can cause cardiac failure, pulmonary edema, and then very rarely the central pontine myelinosis, which is at this point is kind of like a legend. But you rightfully pointed out, there are studies lacking to show that the overtreated patient had a worse outcome or had the said issues peak up later down their treatment line. So that is something have to be looked into. But as you rightfully said, none of these are natural agents that we're giving into a patient. Even as you have personally told me years back, even giving a normal saline to a patient is not a natural thing. And no matter how much normal the word implies in front of the saline, it is a treatment, it is a medication, it is not natural. So that is perfect. That is just perfect. So to conclude, the study recommends 2 non-invasive diagnostic aids, which you would have known, and which one of that you briefly touched upon is the ocular ultrasound, looking for the optic nerve sheath diameter. And the other one is a portable infrared brain scanner, which was something completely new to me, which I had to look into, which obviously tries to find if there is a hematoma in there, which would aid you to say, okay, if there is a hematoma, then it can increase and it can cause a raised ICP. But these 2 things are expensive and not yet in a pre-hospital setting. But do you see down in the future, through your magical glass, do you think these 2 things can actually be brought into practice in a pre-hospital setup?
I think some variation of this might be brought up in the future. So looking at what we have right now, okay, so we have bedside ultrasound. Again, the practicality of using this pre-hospital, I don't want to get into that. I think that's going to be near to impossible doing it on a mobile ambulance or on, anyways. So what we have now is looking at optic nerve sheath diameter. There was a best bets review that came out in 2008, and the bottom line there was if you pick up an optic nerve sheath diameter greater than 5 millimeter, it carried a sensitivity that ranged from 84% all the way to 100%, and a specificity of 63 to 95%. So forget the higher numbers, but you can see that the sensitivity is as low as 84% and specificity is as low as 63%. And for someone who's done optic nerve sheath diameter, I'm sure you've done plenty as well, it's not the easiest of scans to do. There's a lot of things behind it. You need a patient who's, either very cooperative or completely sedated, and it's not a pleasant thing to do. And obviously, you need to get the right angle. We are not, ultrasonographers. We don't scan for a living. We scan to just answer one clinical question, whether there's an optic nerve sheath diameter of greater than 5 millimeter, and this measurement needs to be taken about 3 millimeters behind the retina. It just adds another layer of complexity. So I think when it comes to optic nerve sheath diameter, some kind of improvement needs to happen where if I were to look into the future, I can see some kind of a gadget which is calibrated to take the right measurement, and all you have to do is just place it over the eye. It finds out where it needs to take its measurement and gives you a reading. So this is something which I think may come out in the future. When it comes to portable scanners, based on what you're telling me about this portable infrared scanner, I don't know how useful it is to know that there is a hematoma inside. So my understanding is, based on what you're telling, if there's a hematoma inside, we need to assume there's raised intracranial pressure. Yeah. I think there needs to be a way of probably integrating 2 things. So we need to find out if there's a bleed inside, and we need to club it with another method to say that there is intracranial pressure rise with it. So when you have 2 and 2 together, that's a safer way of instituting treatment. When we use the infrared scanner on its own and we find out there's a bleed, we immediately jump into all our are ways of reducing intracranial pressure, I think we might be going into that territory of over-treating again. Something else which I came across, which I have a feeling it could be something of the future. So it's something to do with cerebral blood flow. Okay, and so there's a formula for cerebral blood flow. It looks at it's basically the amount of blood that enters the intracranial space, and I think this in some way can also give us an idea that there is raised intracranial pressure within the cranium. And I have a feeling, so the way we measure cerebral blood flow right now is you need to know a few things. The formula is it's carotid arterial pressure minus jugular venous pressure divided by cerebrovascular resistance. So there's two things outside in the neck that we could probably get the measure of, okay, the pressure of. So you got your carotid arterial, artery in the neck. You've got your jugular venous, your vein in the neck. I'm sure there's a way of kind of gauging the pressure here. Okay. The only variable we don't know about is the cerebrovascular resistance. If there's some kind of a technology in the future which can give us this unknown, value, we might be able to calculate the cerebral blood flow. And maybe this could help us, come up with a solution of this problem we have about intracranial pressure. And again, it's just, purely sci-fi at this moment. So, yeah.
True. Yes. So, a lot of possibilities. And who are we to say, it won't happen? Because as we can see, medicine is just jumping and bouncing beyond our imagination. So all these Marvel Iron Man stuff could be a reality one day, and we could be just keep a probe and it would measure both the jugular and the carotid pressures for us. Sounds like a plan. So what leads innovation is questioning, asking why, what, how, and I think by just asking the question is the right first step, and by that hopefully we get to a point where it's no longer an instinct, it is hard science. So hopefully till we get there, we will keep asking questions. So I'm extremely happy with our discussion today, and I'm also so happy and thank you for joining me in this YouTube series. And is there anything you would like to add before we go?
Thank you so much for not really encouraging but pushing me into preparing for this talk. You are I'm really glad I actually prepared, put in some time and effort for this talk. It's a good learning, and so the more you learn about topics like these, you understand, and you really become humble about how much you don't know, how much there is to learn. There is no we can't be complacent with emergency medicine, with any medicine. Okay, there's so much to learn. A person can be easily unethical by not being updated. So I think that's really important to understand. That's all. Nothing else to add.
Thank you. So by this, we are going to conclude this video, and thank you for joining the A&E talk.